Welcome everyone to day one of the Ontario West Midwifery Conference for 2025. We are thrilled that you have joined us for this exciting 3-day event where we will explore the themes of advancing research, innovative clinical programs, and leadership in midwifery. Today's focus is on advancing midwifery research, and we have an incredible lineup of speakers who will share their work, insights, and innovations. We are pleased to have more than 130 registrants joining us from across Ontario, Canada, and beyond. This conference was created to celebrate the incredible work of Ontario midwives and to showcase the research and innovation that is happening in our communities. I'd like to start with a land acknowledgement. We acknowledge that this is the sacred land upon which we are privileged to live and work. We recognize the deep connection and long-standing relationship between the Indigenous peoples and the land of southwestern Ontario and London. This land has supported human beings for at least the past 10,000 years and is the traditional territory of the Anishinaabe and Attawandaron and Wendat peoples. We are deeply grateful to be in this place and commit to a continued journey of listening, learning, and building relationships towards truth and reconciliation. Some housekeeping notes. All of the participants' teams' audio and video should remain off during the presentation. All sessions are being recorded and will be available on the LHSC Department of Midwifery website. Speakers' bios will be posted in the chat rather than read aloud. Please use the Teams Q&A box to submit any questions during presentations, and I'll turn my camera on with 1 minute left to help presenters manage their time. At the end of the day, we'll share a QR code for our feedback survey. And to start with, I'd like to welcome Lauren Columbus, who will present on the evaluation of a novel midwifery maternal fetal medicine collaborative program. You can go ahead, Lauren.
Thanks so much, Sarah, and thanks to everyone who's here today. I really appreciate having the privilege to share the results of our evaluation of the TIME program. And I just wanted to acknowledge my really wonderful study team that I have here. It was a collaboration between LHSC and McMaster. And yeah, it's been a lot of work over the last year and a half, so I'm excited to share. Last year, I presented at this very conference the framework that our study team had selected for our evaluation of the TIME program, and it was called the REAIM framework, which I'll describe in a minute. But just to give a quick Coles notes on the TIME program for those who aren't familiar, we are a small program based out of LHSC, which is a tertiary care center in Ontario, and it consists of 4 midwives who provide collaborative antenatal care and education and postpartum care to about 170 high-risk pregnant people and their infants every year in collaboration with our maternal fetal medicine specialist team. We're funded by the Ontario Ministry of Health's EMCM, our expanded midwifery care model funding, and we have a specific criteria for referral to our program that includes a variety of social and medical indications. We generally, recognize that there's a group of people that would benefit from having sort of complex care plans, and that might require close ongoing community-based follow-up after hospital discharge. And that's sort of the goal of the program, as you can see here. We designed this program based on our knowledge of the existing literature that highlights the disparities and outcomes faced by people who experience both medically complex pregnancies as well as those who are impacted by the intersection of various social determinants of health, or SDH. As you can see, our referral criteria here really addresses all of the sort of different social determinants of health that we know are supported in the literature as having impacts on perinatal outcomes. We launched exactly 3 years ago. Since then, we've expanded a little bit. We're now funded to 3.0 FTEs. We have 24/7 pager access, 7 days a week. We do home visits for all postpartum visits to reduce transportation barriers. Our numbers reach about 10% of the total MFM population here at LHSC. I really wish it could be higher, but we're going to need some more funding for that. And we created free prenatal classes that were tailor-made for high-risk populations. And we have a lot of no-cost access to kind of basic postpartum items like free pump loans, pump kits, diapers, donation bank, etc. And at the end of our second year, we formally grew our study team to launch the evaluation of the program, and really wanted to look at our reach and our outcomes, and started our data collection. So that's what I'm going to dive into here. But I just wanted to point out that, as we know, SDH and medically complex pregnancies have really significant overlap. And as we worked in the first few years of the program, it really highlighted the need for, equity-informed care, and triggered this question about how we could use the sociodemographic data from our clients to really help our program provide sort of the safest and most personalized model of care to our patients. And that was really the sort of impetus for starting this study. So our study purpose here, as you can see, is to holistically describe the population that we serve, analyze the care provided, and really assess the clinical outcomes to understand the impact of our program. And it was also to understand the perceptions and experiences of the healthcare providers and patients who work in the program. As I mentioned before, last year I described the framework that we were going to use, and so I'm just going to quickly show it here. The REAIM framework talks about the reach, effectiveness, adoption, implementation, and maintenance of a specific health intervention that you've introduced into a hospital system or a healthcare system in general. And so it talks about things like, who is the program intended for? What is the effectiveness in terms of, the important outcomes that you want to measure? In terms of the adoption, was it adopted the way that you intended it to? Who did it and how? How much did it cost? So, I highly recommend looking into it if you have a similar program, and want to sort of also evaluate the same things in terms of the efficacy of your program. To do this, we broke the study down into 3 parts. So we had a quantitative evaluation of the clinical outcomes and health services usage data, and that was completed using a retrospective data analysis from patient charts. We also had 2 qualitative portions, and that was a part about the patient experience and the healthcare provider experience. For the sake of time, I'm going to just focus on the quant data today. However, if you want to hear the whole thing, you can catch me at the MMRC speaker series in January, where I have a bit more time to go over the entire results of the study. So we used a retrospective chart review. As I mentioned, we included all patients who accessed the time program in the designated time period. That led us with 201 maternal patient charts and 230 infants who met eligibility criteria. And the data extraction was performed on site by 2 team members using access to all different electronic and paper medical records, and it was all stored in the REDCap server. So this is obviously a very time-consuming endeavor, and we can talk a little bit about that afterwards. Another thing I just wanted to point out is that there is a fantastic article published in the JOGC last month, and it was about looking at outcomes for Black people from a perinatal perspective, specifically around morbidity and mortality. And just a couple of quotations here for those who haven't read it, or if you want to go look it up, but they talk about how Ontario really lacks a standardized method to routinely collect and govern information around demographic data, and that it really means that we don't know how different aspects of SDH sort of intersect, especially in terms of racial and ethnic groups. And they felt in this commentary that was published that it's really critical to have this information. And I know Born is doing a lot of work on trying to look at ways that this can be properly collected going forward. And I would really advocate for that based on how much work it was to find this information retrospectively. And it makes it hard to do these evaluations. Moving into our results section, we started with just sort of some patient demographics and factors that might have been related to the referral. So as you can see from our chart here, we had 40% of our patients were receiving income assistance. 39% had identified that they belonged to a racialized group. When we compared all of these numbers to sort of the baseline provincial or national data, we felt quite successful in our reach in the program, and that generally our numbers were quite a bit higher. So as you can see, London's baseline population at 29%. Same for other key indicators like bereavement cases, reports of intimate partner violence, mental health concerns, and other, really important either medical or sociodemographic factors in medically complex pregnancies. We also looked at the pregnancy and health history for all of our patients as well. Obviously, these are patients who are enrolled with, who are having care from maternal fetal medicine. So most likely they already do have something in terms of their own medical history or a pregnancy history that does make them medically complex. And we just wanted to make sure that that was accurately reflected as well in the people who were being referred to our program, which it was. So our general breakdown is that roughly, 54% had a pre-existing medical condition. And you can see on this slide the breakdown in terms of some of the most common medical conditions being cardiovascular, neurological, or endocrine. We had just shy of 30% who had maternal pregnancy-related complications, generally during the pregnancy itself. And then we had about 30% who had fetal or neonatal conditions that sort of triggered their MFM referral. In terms of the breakdown of some of the fetal conditions that were noted, a decent proportion of those were fetal growth restriction or abnormal fetal Dopplers. And then we had also a breakdown between minor anomalies and major anomalies that were largely caught on the second trimester ultrasound, which also triggered the referral to both MFM as well as the time program. In terms of our mental health concerns, this was a big and very important referral criteria for us, especially in terms of the additional midwifery support that they would have antenatally and postpartum. It's a really difficult one in terms of assessing the impact because our midwifery care ends at 6 weeks. And so from an effectiveness perspective in the REAIM framework, we didn't have a really great way of assessing whether, people's mental health status was improved at 6 weeks postpartum by virtue of having the time program involved. Most of the clients who have identified mental health concerns in our program, these are lifelong mental health concerns that are often very complex and very severe. And so, it's hard to evaluate the way that 6 weeks of postpartum care as sort of a blip in time might have a greater impact on their overall mental health status. But suffice to say, we, at least from a reach perspective, knew that we were reaching this population. You can see some comparators in terms of the number of people. For example, we had just shy of 68% who had a current mental health concern or a previous one. And if you look at the baseline population, we were about double the rates of anxiety diagnoses and almost triple the rates of depression diagnoses as well. So we felt like we were adequately reaching this population. As we move into the effectiveness piece, these are just, again, a quick snapshot of some of the outcomes for our time population. So you can see we had roughly a 20% preterm birth rate, 23% NICU admission, and 23% low birth weight. We had just shy of a 40% cesarean section rate, and you can see a few of our breastfeeding results. So a 50% exclusive breastfeeding rate at 6 weeks. And just over 80 for any breastfeeding. And we'll talk a little bit about those two in context next. in terms of looking at sort of some of these outcomes, we know compared to general population data, mostly collected either by CIHI or through the Public Health Agency of Canada, that we certainly had higher rates of cesarean section and preterm birth than the general population. Our NICU admission rate was also quite a bit higher than the baseline population, which was to be expected. And even things like our low birth weight instances, we had a 23% low birth weight instance versus the CIHI comparator of just shy of 10%. So it's quite a bit higher in those outcomes. From a health service usage, one of the pieces we were most interested in was looking at postpartum emergency department use, particularly because they have pager access for 24/7, and they have frequent postpartum visits from the midwives. So we wondered if there would be the same sort of impact on ED usage through these mechanisms as there is in the general midwifery model. And there's excellent data published by Carla Sorbara in terms of her studies on postpartum ED visit use for clients in midwifery care versus OB care. The problem is that we don't have a great comparator for high risk or medically complex pregnancies in the time program to not receiving midwifery care. So we don't really know what to do with that data, but we do know that we did have a higher postpartum ED visit usage at just shy of 11% versus midwifery and OB care, as you can see here. Our most common reasons for ED use for the maternal birthing person as well as infants were a little bit different, though. For example, for infants, it was based on infection, which makes sense in a significantly preterm and low birth weight population, versus the Ontario infant ED data usage, which is mostly for jaundice and feeding issues. So we felt at least successful in that realm, that we were reducing those visits by having good midwifery follow-up. Our breastfeeding results were another key point for the efficacy of the program. And as you can see here, we actually increased our breastfeeding at 6 weeks of age across most of our infant populations. And that's sort of the exact opposite of what the Canadian national data shows, which is generally that breastfeeding rates start out very high in hospital and then drop off quite significantly. We had the opposite effect, which again, we felt like was likely, pretty demonstrative of the impact of postpartum midwifery care. And so that was something that we felt at least we could use from an efficacy perspective. So I'm just going to wrap up now because my time is up. But in terms of conclusions, we really, as I mentioned, felt that we were effective in our fidelity to the original goals and designs of the program. And we felt we reached a population who is really disproportionately impacted by the social determinants of health. We felt our breastfeeding rates had improved from baseline population and hospital rates, and had an overall low readmission rate despite the complexity of our population. Our study wasn't adequately powered for correlational analyses, but our data did show a correlation between postpartum ED use and mental health diagnoses and income assistance. So that's something interesting to look at going forward. And also, we really came across the piece that the need for individualized care really struck a chord with us in terms of our analysis. So as we know, the current prenatal appointment model that we have is over 90 years old, and it likely does not reflect the needs or realities of our current population and their health indicators. It also doesn't match our current knowledge of maternal and fetal disorders. But even in our model, it was really hard to sort of break away from the standard model of prenatal and postpartum care. So our health service usage wasn't altogether that much different in terms of the number of visits people got compared to the general population. And I know old habits die hard. So that's probably part of it. But I think, it really points to this need for much more tailored and individualized pregnancy care for high-risk populations. So I'm going to wrap up now. But yeah, thanks so much, and happy to turn it over to a question or two if I have time.
Thank you so much, Lauren, for sharing. We don't have any questions in the Q&A box, but I do have a couple of questions. So first of all, can you speak to the importance of collecting the kind of data that you have collected for time, and why do you think it matters?
Yeah, it kind of speaks a little bit to what I mentioned in terms of this importance of tailoring and having a really individualized approach to the care that we provide for vulnerable, marginalized, high-risk populations. The problem is that it's very hard to collect, as most of us know. There are portions on the Ontario perinatal record that asks for things like education status, whether people are working or not, and in some way the sort of ethnic and racial background for the egg and the sperm. But there's not, it's not necessarily rigorously collected, and it's certainly not currently entered into any provincial databases. So doing any type of analysis this way is really hard, as far as linking, why do we still have such poor outcomes for, certain populations affected by SDH. And so collecting this data helps us answer those questions, and then theoretically would help us build better perinatal care to address those discrepancies.
Great. Do you have any advice for any midwives or EMCMs or MPGs that want to start a data-based approach to quality assurance or evaluation, but they don't know where to start?
Yeah, well, for our study, finding a good framework was really helpful. So, being tipped off to the REAIM framework, really kind of, it's obviously like an evidence-based and sort of a validated way to evaluate a program. And so you can find whatever evaluation model or framework works for you, but having one that's like all the work is already done, it tells you what you need to look for and how, is really helpful. And then in terms of actually collecting it, if there's a way that you can build it into your charting so that you can then make that collection a lot easier. We didn't have the ability to do that with the way that our system is still on paper, which is terrible. But it meant that there was no way, to have our, let's say, our decision support crew at the hospital just pull through everything and provide us with that data. We had to hand pick it. And I did see a question pop up about how we got the funding to do that. Yes, the study was funded, but the time to actually do that data extraction really was a medical student who volunteered her time, and myself as well. So, it's a really unfortunate reality that, our time wasn't necessarily compensated for that. And that becomes really hard for other programs to do. We just happen to be at an academic center with medical students who want to get involved in research. And then we had a small amount of funding to help with Beth and Julia's time as well. But I recognize that's a big barrier. Yeah. And I'm happy to chat more about that in the Q&A while the next group goes ahead. Yeah.
Okay, wonderful. Thank you so much for speaking with us today, Lauren. That's very interesting. I'd like to welcome Sherry Matthews and Tiffany Sodermans, who are going to be presenting on human lactation clinical updates for optimal infant feeding support. You may now share your screen. Just a quick intro. Sherry is a registered midwife and a certified breastfeeding specialist with a background in nursing, and Tiffany is a registered dental hygienist, as well as a certified breastfeeding specialist and an IBCLC. Welcome.
Hi, I'm Sherry. And I'm Tiffany, and we're going to talk to you today about human lactation updates. We found it's an important area where information is constantly evolving and at times being influenced by what's trending on social media. As professionals, it's important that we stay up to date on current recommendations so we can confidently support families with accurate evidence-based information. Our learning objectives today are understanding the benefits and indications for colostrum harvesting, review evidence-based practice for flange fitting, apply current mastitis management guidelines and lactation care, Implement updated strategies for treating cracked and sore nipples.
So first, we're going to talk about colostrum harvesting. What is colostrum harvesting? It is the expression and collection of colostrum while pregnant. Currently, the Academy of Breastfeeding Medicine does not have a protocol or stance on colostrum harvesting, and as an IBCLC, the ABM is somewhere where we often reference for direction and treatment on lactation and breastfeeding challenges. So this is unique in itself that there's no stance on it. Other countries, such as the UK and Australia, routinely include colostrum harvesting in their care and discussions with parents. And it is something we should consider ourselves in practice, especially given the social media trends on colostrum harvesting and the global reach of what other countries routinely practice. It's typically recommended from 36 weeks onwards and cleared via the midwife or OBGYN. And some sources even indicate around 35 weeks. So let's talk benefits. Two main benefits of colostrum harvesting. One is learning your own breast anatomy and how to hand express prior to birth. That can create confidence and understanding of how breasts work and how they feel and the technique in itself. This can be a game changer in those early hours and days postpartum. And second, when harvested, colostrum in itself is available. So it can be used in instances where breastfeeding is delayed, a baby is unable to feed at the breast, or there's health complications. When considering if colostrum harvesting is right for your patient, we want to look at the big picture. Is there any medical conditions, diabetes and pre-existing gestational, or baby medical conditions, IGR, or circumstances such as planned inductions or C-sections? These having harvested colostrum can be beneficial after birth, especially when there's a delayed onset of milk production or delayed initiation of breastfeeding. Preparing in advance with colostrum harvesting can be a huge help. Additionally, colostrum harvesting can be helpful and beneficial, but is not indicative of a full and mature milk supply. It is important to be transparent with parents and to set expectations. Colostrum amounts can vary person to person, and it is important for parents to note that they may get drops or nothing in the beginning and even throughout their experience, all while others may get several milliliters. This can vary and should not be a comparison game. Can all be normal. So this is where social media can create a source of stress regarding colostrum harvesting and what is normal. So again, setting expectations with families and practice of hand expression prenatally is beneficial regardless of whether colostrum is even collected. And then colostrum harvesting is not necessary in every parent's journey. However, the idea is to have potential colostrum available in circumstances like mentioned above, and to gain confidence in that hand expression. That confidence really can set the tone for the parent's breast and chest feeding journeys. Finally, taking that time to teach the proper hand expression and reviewing safe collection and storage with families. Kits are readily available in places like Amazon or medical supply stores and are pretty accessible in terms of that. And then lastly, I recommend reviewing the DAME study that was completed in Australia around 2017. It is a great resource. It is really one of the only primary sources to show the safety of colostrum harvesting and the benefit, especially in those with diabetes.
Our next topic is flange fitting.
So with flange fitting, traditionally flange fitting, and what many of us may be familiar with, is measuring the nipple and then adding 3 to 5 millimeters. And there we have it. That's the perfect fit, but that's not quite true. Most pump companies now provide sizes 21, 24, and 28 millimeter flanges. And along with that, they have a handy little measuring guide that relays all that above information. While there isn't one perfect way to flange fit, what I'm going to talk to you about today is an alternative method to try and practice, and that is an improvement over the traditional methods. Jeanette Mesquite Fern is an IBCLC, and she created the Flange Fits guide that's currently on the screen right now. And this is just kind of a condensed version of the general fitting process, but gives you an idea. It is a great resource, and it's available in over 20 languages to help both parents and practitioners get the proper fit. So it's a great resource, and we have that linked for you. This method goes against most aspects we were traditionally taught with flange fitting, so keep an open mind as I chat away here. The idea in general is not taking the quick route. We are not just slapping on the first size we see and measure and adding 5 millimeters onto that. We are taking a more methodical approach with this. This method, you start by measuring the tip of the nipple versus the base, which is already a little bit different than traditional measuring, and use that measured size, and ideally one size above that and one size below. And so if you measure a nipple at size 15, we're also going to try size 14, 15, and 16 size flanges on that parent. And we're also ensuring we're measuring both nipples. They can be different sizes, not always the same, and that we revisit sizing throughout lactation if we see difference in pumping. With this method, we are also taking the time to not only try alternative sizes, but we're looking at that overall fit. So we're looking for the nipple in the tunnel, no areola. The nipple touching the sides of the tunnel is actually ideal, and using things like coconut oil can help with the lubrication. We are actively pumping during these fittings, turning the pump on to check for comfort. And what we see being expressed and how the size correlates to that. So it's truly not a first try approach. It takes time. Beyond that, we are also looking at varying types of flanges. There are inserts, silicone flanges, hard flanges, and there's also multiple shapes. Crater, pano, comfy, oval, just to name a few. Now, I know this is a lot, but stay with me. It's shocking, but different breasts work better with different shapes of flanges. So all bodies and breasts are different, and this approach takes that into account versus just standard hard flange and taking no consideration of the body attached to the pump. Briefly noting that along with flange sizing, pump settings are also an important part of this process and can vary per pumping parent. There's no perfect pump setting across the board, and doing a flange fit, during the flange fit, it's best to play with these settings to see what yields both comfort and milk sprays for the parent. It is important to recognize if a parent is struggling with pumping, one of the first things to consider is what size flanges are they using? Can adjustments be made to those sizes, and are they comfortable? Often parents go right to what came with their pump, and they measure with the instructions given by the pump company, which unfortunately across the board is that traditional method we all know. Thankfully, flange sizes are now available in sizing ranging from 10 millimeters up to 32 millimeters, and they come in a variety of shapes and materials that can be trialed, and even inserts that are available to come in a variety of sizes and typically insert into an existing 21 or 24 millimeter flange. And they can be a more affordable option for sizing for parents versus purchasing various hard flanges. Of course, there's barriers to this updated method. The cost of flanges are an investment for parents to try multiple sizes if they don't have someone that has them available. And there's compliance and patience of trialing multiple sizes. However, it can make a big difference in both comfort and milk expression, and worth the consideration to update your recommendation to parents. Encourage providers regularly working with pumping parents to consider one of Jeanette Mestine's courses from Babies in Common. They go in more in depth from what I just did now, but that's all. Thank you.
Here's a link to the flange fit guide that Tiffany was just talking about. So that's free for anyone. So you can take a look at that link and get that information. I'm going to move on and talk about mastitis. So today we'll look at the latest guidance from the Academy of Breastfeeding Medicine, the ABM, the clinical protocol number 36, called the mastitis spectrum. It helps us understand mastitis as a range of related conditions, from early inflammation to infection and abscess formation. ABM emphasizes that mastitis is not all bacterial. It can begin as inflammation or milk status, and only some cases progress to infection. By recognizing where a person is on the spectrum, we can give the right care at the right time. It can start with duct narrowing or inflammation, then progress to bacterial infection. A phlegm is a spreading area of inflammation inside the breast. A galactocele is a milk-filled cyst caused by a blocked duct, or abscess, which is an infected pocket of pus. So each stage needs a slightly different approach. So most mastitis can be diagnosed clinically with a red hot area noted on the breast. Oftentimes a fever comes along with that. They start to feel unwell. If symptoms persist beyond 24 to 48 hours, or there's a firm lump that can be movable or compressible, ultrasound is the best tool to rule out abscess. The ABM encourages continuing breastfeeding or milk expression in most cases, but they note that increasing milk removal beyond normal can sometimes worsen the swelling. So in other words, if you're pumping, only pump the amount the baby needs and not aggressive to empty. Supportive care is key. As seen on the slide, the BAIT stands for breast rest, acetaminophen and Advil, ice, and therapeutic massage. Breast rest meaning that you're only going to use your breast to feed, and then you're going to rest in between. And along with Advil and Tylenol and ice can be helpful. If you're going to massage your breast, you need to be very gentle with your tissues. And so it's like a gentle touch, like petting an animal. Not all mastitis needs antibiotics. If symptoms suggest a bacterial infection or the person has systemic illness, antibiotics are appropriate. But overuse can disrupt the breast microbiome. So therefore, the ABM recommends using them only when clearly needed and always with continued milk removal. So we want you to continue to feed, just not aggressively emptying the breast. Mastitis prevention is mostly about milk flow and comfort. Supporting effective latch and avoiding milk status are the best ways to prevent implementation. So moving forward, we're going to talk about the updated care for cracked and sore nipples. Some of this information may be a very helpful review for many of you. Well, for others, it may introduce some new concepts. Sore and cracked nipples are common in early postpartum period, which is a frequent reason for early weaning. The most common cause for cracked and sore nipples is incorrect latch and positioning. Other causes can be from feeding too long, infants clamping down to avoid a forceful letdown, improper flange fit, or overpumping and high suction, followed by trauma from misdirected sucking. Other causes include skin conditions such as eczema, infectious causes such as bacterial cellulitis, nipple thrush, or vasospasms. The physician guide to breastfeeding states that nipple wounds should be lubricated and covered to heal effectively, just like burns or other open wounds on the body. The first line treatment includes optimize the latch and positioning, followed by applying an over-the-counter lanolin. You can also apply a hydrogel soothing pad that can create a moist, protected environment for healing. It is recommended that to keep the nipple covered both day and night to enable uninterrupted wound healing. Avoid excessive cleansing as it can remove natural oils and predispose to breakdown. The advice is care for the nipple like any other surface on your skin. It's important to note that superficial nipple trauma often heals within 8 to 10 days if well managed. So we may not see healing right away, but it will come if we continue with this care. As most of us have been prescribing Apno for years, but there is a change with that. The recommendation is to avoid Apno until all options have been used. The reason for this is due to antifungal and antibacterial components not indicated for a normal nipple wound, unless there's a confirmed infection. If a steroid is needed, it should be prescribed separately and only in appropriate cases. So instead of giving the Apno right away, we should be correcting that latch, adding the lanolin, trying the hydrogel, and if still pain after some time for healing, then you can add a steroid, which we can over the counter is the 1% hydrocortisone that they can apply to their nipples after feeding. It doesn't need to be wiped off prior to the next feeding, but it can take away that pain, which could be helpful. Mind you, if we find that this is not helping, then the midwife will need to consult the family doctor for a stronger steroid to be given. I wanted to mention about silverettes, as it is a common and popular amongst our clientele. Although it is emerging, the evidence is limited. It may be useful for some people, but not universally recommended as routine. If used, it is recommended to be used along with no added nipple ointment, as it can act as a barrier, interfering with the antibacterial properties. So just to kind of note that, it is out there. A lot of clients are buying it. It is expensive. It can be helpful. However, it's not changing the ABM's protocol and advocating for it at this time. In summary, colostrum harvesting can empower families and support early feeding, especially in high-risk pregnancies. Flange feeding is essential and should be revisited throughout lactation to optimize comfort and output. Mastitis management emphasizes addressing inflammation first with antibiotics used selectively. Cracked and sore nipples benefit from positioning corrections and targeted topical care. We just want to thank you for your time and being part of our presentation today.
So I would like to welcome Elizabeth Nethery, who is going to present on the power of policy transforming access to reproductive health care in Canada. And you can feel free to please share your screen by taking control. Elizabeth is a healthcare policy researcher whose work explores how policy can improve access to reproductive health care across Canada. Her research bridges evidence and advocacy to support equitable healthcare systems.
As you mentioned, so I'm going to switch gears a little bit and kind of just focus on some new reproductive health research that I've been involved with across Canada. So this is, although I am a midwife, this is not particularly midwifery-focused research. I have done midwifery-focused research, and this is not necessarily that. So this is more just kind of sharing some success stories and some of the new and groundbreaking research that we've been involved in over the last couple of years. And thank you so much for having me. All right. Okay, so when I talk about reproductive health care, I'm really talking about contraception and abortion care primarily. And what this is something that, of course, I'm sure we all know really is important because it leads to an improvement in the ability of pregnancy-capable individuals to control their fertility, to choose pregnancies if and when they want to become pregnant, to space pregnancies. And it also contributes to improvements in gender equity and education, employment, and generally just better health for everyone. So one of the tools that we can use to improve reproductive health broadly is what we call health policy. And that can include a lot of different things. So that can include everything from scope of practice changes, guideline changes, continuing education, community-related projects such as social media campaigns, patient education. And it can also include really broad things like facility changes at the structural level, introduction of new drugs, and also payment reform. So the first example that I'm going to talk through, which is going to lead into some of the sort of new research that I've been involved in, is focusing on abortion. Oh, my slides are not going ahead, are they?
No, they're not.
No, they're not.
I just realized that. Okay. Sorry. We'll just do it this way. Sorry. Now they're going ahead.
Yes, that's perfect. Thank you.
Okay. Sorry, they were going ahead from one. We'll just do it this way. I don't need my notes. Okay, so here we are. So the first case study I'm going to talk through is around abortion healthcare in Canada. So as most of you know, abortion was decriminalized in Canada in 1988. This is sort of one of the countries in the world where abortion is not regulated in any laws, which is actually a good thing, because what that means is that it's regulated through the normal health professions processes. So we have legislation around scope of practice and who can do what through training, but we don't have explicit laws around abortion. And until recently, I guess 5 years ago or more now, almost all abortions in Canada were what we call procedural abortions that occurred in centralized facilities for the most part. Medication abortion was very infrequent. And we were seeing really inequitable access to abortion, in part because of the fact that everybody would have to travel to most people would have to travel to centralized facilities to access these services. And one of the big kind of policy changes that came in was the introduction of mifepristone, which is a medication that is used in abortion. And it was introduced in Canada in 2017. And Canada was actually really late to the game to introduce mifepristone. This was something that had been used in other countries for quite a while, so there was already robust safety data available. But when it first was introduced, there were some restrictions placed on it in terms of how it could be used. But those were really quickly lifted in Canada, and Canada became one of the sort of unique places in the world where mifepristone could be prescribed like a normal routine medication, and there weren't any specific restrictions. And so the question is, what happened in Canada with the introduction of medication abortion? Did this actually have some of the impacts that we hoped it would have? And so some of the early research on this, led by various people, a lot of whom is Dr. Wendy Norman at UBC and Laura Schumers as well, who I work with, really found that this didn't, first of all, this didn't make abortion less safe. So that was the first piece. The second piece was looking at, did this improve the number of providers that could provide abortion care? And it did. And we also looked at pharmacies. So some really new research that just came out was showing that actually in Ontario, before mifepristone was available, less than 2% of pharmacies would fill a prescription for some type of medication abortion, whereas afterwards it was about 20%. So that's a big improvement, but the question is, okay, that's still only 20%. Is that because the rest of the pharmacies aren't being asked to prescribe this medication, or is that for some other reason? And so that also, just to add to that, we knew from other research that pharmacists were generally very positive about this, but that they did cite some barriers. So this is an expensive medication, and the way the system works, most pharmacists are reimbursed for the medication by the government because it's covered in all, it should be covered in all provinces, but they have to pay the initial cost of the medication until the patient requests it. And so that's one reason why maybe they don't have it in stock. And there can be low demand. It's not a really common thing to be prescribing in the community. And then there were some misconceptions around training. So this leads me to the study that I'm going to talk about, which is we were really trying to understand whether these potential gaps in care around finding a pharmacy that could dispense mifepristone were a big issue or not. And this particular study was in BC. And this is building on some other work that had been done where they looked at whether pharmacies had mifepristone in stock and found that actually in some cases only 6% had it in stock. So this study is coming out in about, a week or a week and a half now, so it's not yet published. But what we did was we did what's called a mystery caller study, or a secret shopper design. So this is where you have a couple of people who called every pharmacy in BC over the summer of 2024. We had a couple summer students who did this. They called over 1,400 pharmacies, posing as a patient, just saying, I want to fill my prescription, and followed a set script. And what they found was that actually about 2/3 could fill their prescription without any problem. And there was a small minority who referred appropriately. And then there was still a non-trivial group that couldn't fill the prescription. And we didn't ask why. The purpose of the study wasn't to get into the kind of details of this. It was really to find out what a patient might experience. And then we looked a little bit more in a nuanced way at rural versus urban pharmacies, and we actually found that the rural pharmacies were more likely to fill the prescriptions, which was interesting. And we speculated a little bit that maybe this is because rural pharmacies are better at paying attention to their medication stock. But we don't exactly know why. And then we looked at where the mapping of where people lived relative to these pharmacies, and actually found that almost everybody lived within 15-minute drive of a pharmacy. So, we should be seeing good access. And then we did a little bit more of a nuanced dive into the proportion of pharmacies, so where there were kind of a high density versus a low density of pharmacies. And then we found that actually there were some really interesting pockets, especially in the urban centers, where there was really a low density of pharmacies that would prescribe this medication. And what we concluded from this was that actually this was potentially a referral issue, because so that yes, in some areas patients would have to call around because their pharmacies didn't know where to send them. And so our call really here is that generally when mifepristone is available, it actually can be well implemented in the community setting. And for the most part, things looked pretty good in BC. However, really, there were improvements that needed to be made to referral networks. So I'm going to switch gears to another case study. And I'm going to have to say it's a little hard for me to manage my time because we started at an odd time. So I'm just going to keep going here. But this is a different case where I'm talking about pharmacare for contraception. And so, as I'm sure most of you know, the federal government called for a national pharmacare plan some years ago. You guys haven't seen that rollout in Ontario, but in British Columbia, we have seen some of that rollout early. And so I'm going to talk about an evaluation study that we've been involved in where we're trying to evaluate the impact of this. So the reason for pharmacare for contraception or for universal coverage is that as you know, most provincial insurance plans don't include universal drug coverage. And contraceptives are potentially a really unique prescription group because people may not want to claim this kind of coverage, even if they do have private insurance. So sometimes people, this is also something that most reproductive age females will have to access or will choose to access at some point in their lives. So it's something that is highly used. And it's also something that the current approach may be insufficient because people may or may not want to sort of acknowledge that if they do have a shared drug plan, for example, with a family member or a spouse, there can be issues of reproductive coercion or other reasons for them not to want to put this on their insurance. And so in this case, we know that from other research we've done that cost really does impact choice. And particularly when it comes to things like LARC, which is the most expensive, most effective, but has high upfront costs. So that's IUDs and subdermal implants. So in BC in April of 2023, so predating national pharmacare, BC was kind of a landmark province, and the BC government brought in a universal coverage for all contraception. And the way they did this is they latched this contraception coverage onto an existing public drug plan. So in most of the provinces, there are these public pharmacare type drug plans that exist already to cover specific populations. And in BC, there's one particularly that does cover 100% of the province, specifically for things like mifegamizumab, which is medication abortion, medical assistance in dying medication. And these are medications that have been legislated to be covered nationally. And so what they did is they just added the contraceptive group onto it. They didn't cover all contraceptives initially, and that matters a little bit, but for the most part, all long-acting contraceptions were covered. So the research question is, what happened after this became free? We would hope this would have a positive impact, but how much of an impact did it have an impact? So how we studied this is we got access to a national prescription database, which had all contraception prescriptions for all provinces per month and in some subgroups. And we used a method that's called an interrupted time series, which is really just a fancy way of talking about time trends and looking at the interruption and the effect of that interruption. And what we do with this is we measure the rate of change, so the blue line before a policy change, and then we compare that to we sort of extend that policy out in time to what we expect might have happened, which is the dashed line. And then we look at what actually happened, which is the blue line at the end of the policy, at the post section here. And we say, okay, well, what's the difference here? And that gives us a really precise way to measure the effect of a policy change, controlling for other underlying time change that might be happening. And then in this case, we also looked at control provinces. So that's the yellow line here. And statistically, we are able to kind of control for those as well. So the first piece of information we found is that we looked at the proportion of prescriptions that were for LARC. So this is IUDs and hormonal contraception. And what we found was that following the policy change, there was an immediate increase of about 1,000 more per month dispensations for LARC, which is a pretty massive policy impact, which is a lot more than we expected. And then this continued, and by the end of March, so 2 years after, there was still this large additional over what we'd expected prescriptions for IUDs or implants. So that's a pretty huge policy impact. And it tells us really that cost did matter. Then we looked in age groups and we actually found that the biggest impact was in the 20 to 29-year-old age group here, which again is just telling us that potentially that group was really experiencing an access gap with the existing system. And finally, we looked at this. This is looking at the proportion of contraception which is paid out of pocket. And the black line here is BC, and all of the other kind of squiggly lines are the other provinces. And actually, the purple line is Manitoba, because Manitoba, a few years after BC, implemented a similar policy change. So, so it had a similar policy change. And so what we found here is that there was a really substantial decrease in the proportion of contraception that was paid out of pocket. Surprisingly, BC already had a lot that was paid out of pocket before the policy. So it just really tells us that BC in particular was not doing well with the current system, but really that this is a type of contraception where a lot of people are paying out of pocket across Canada. So just to sum up, what we found was that this universal first dollar contraception, so kind of universal pharmacare, really had a huge impact on people's choices. It decreased out-of-pocket costs, and it shifted people away from potentially less effective towards more effective long-acting contraception. So just to, again, recent bold action on reproductive health policy has really led to substantial changes, both for medication abortion and for contraception. And that's the end of my talk. I just want to acknowledge Dr. Laura Schumers, who's been a big contributor to some of this work. Here's a bunch of the research that I've mentioned if people want the links. And a couple of op-eds that we have just published in the last couple weeks on this kind of work. And I'm happy to take questions. Thank you.
Wonderful. Thank you so very much. I don't yet see any questions in the Q&A box. But I'm wondering if your research or any other research has demonstrated that the cost is a primary barrier as opposed to access to a healthcare provider, such as a family physician, a nurse practitioner, or a midwife who could prescribe contraceptions and or insert a LARC. Do you know of any research on that?
So there's a couple things. The fact that we saw as big a policy impact as we did from this particular pharmacare policy tells us that cost was a barrier, because there was no change in this period in the number of providers who were able to offer contraception. In terms of, well, that's not totally true. There was no change in the providers who could offer insertions, particularly. Okay. What we do know that I caveat that by saying that unfortunately in BC, 2 months after this policy came in, pharmacists were able to prescribe all contraception. So there was actually a massive change in prescribers that happened in June of 2023. And we can't disentangle that because the policy changes happened essentially at the same time. But that isn't going to impact IUDs. Because you still have to wait for a provider to do the insertion. So as far as the other types of prescription medication, we actually saw kind of a really incremental increase in short-acting contraception use. And I've put the links for all of these papers. Like there's a ton more work on this and a ton more data that I haven't shown in terms of the nuances of all of this. But yeah, that's the short answer, is that we know that cost must have been a barrier because we saw such a huge impact.
Okay, wonderful. And we do have one other question that just came in the Q&A box. Jasmine has asked if there has been any examination of therapeutic abortion or birth rate since the legislative change.
Yeah, so there has been. I was trying to squish a presentation into 15 minutes. So that is, there's a bunch of work that's been done that actually Laura Schumers has led in looking at rate changes. So there's 2 recent studies, one, both of which looked at changes in rates. And there's one that's in, I think it's in, there's one in JAMA, JAMA Network Open, I believe, that was just published this year. And what they found was really that it's nuanced when we look at rates. And so the overall rates of abortion did something funky because they went down in COVID and then they went up again. And so there's been a lot of question worldwide whether abortion rates have actually increased. And what Laura found when she looked really carefully at this in Ontario, this was Ontario data, was that there was a very small increase in abortion rates following the introduction in this last time period, in this kind of post-COVID time period, because part of the challenge is that everything went down in COVID. And so when you look at changes over time, you have to take into account the COVID years, which were an anomaly. And so what they did is they looked at the pre-COVID trends and then kind of pulled COVID out and then looked at the post-COVID trends. And I think there is an incremental increase. And what they interpret that is actually as perhaps an unmet need for abortion care before mifepristone was introduced, and that we're now just seeing that kind of incremental increase. We are seeing a massive shift towards medication abortion compared to before.
Thank you so very much. We really appreciate you joining us today. Yeah, you're welcome to stay or carry on with the rest of your day if you need to.
Thank you. I'm happy to take questions.
Okay. Thank you. I think those are the questions that were posted. So if we have any others, we will forward them to you for sure. Now I would like to invite Megan Furnival and Ginny Brotman to speak. Megan is the lead for the Department of Midwifery at LHSC, and Ginny is a researcher who specializes in evidence synthesis and knowledge translation. And I think we just have to get back to the right slide.
Yes, I believe we start on slide 34, I think is what it is.
Yep. That's where we're at.
Perfect. So Ginny, if you want to take control of the slides first, and then I'll go when it's my turn.
Okay. I'm just going to have to scroll through till we get to
No
that
worries.
slide, I think. So 34, bear with me a sec, folks. Okay. Here we go. Okay. So I'm going to start us off. Thank you very much for the opportunity to talk to you all today and to hear about the great research that's going on in Ontario West in the Midwifery Network. I am an associate professor of nursing at Ontario Tech University in Oshawa. I'm a nurse and midwife. I study mostly midwifery research, and I'm very interested in evidence synthesis because I've worked almost 30 years in the methodology of systematic reviews and how you involve stakeholders or interest holders in systematic reviews and applying them in lots of different contexts. So today, I'm going to focus on how we can build research capacity in midwives and hopefully other healthcare professionals through the use of evidence synthesis. This is a very early project, and I'd like to acknowledge particularly my co-investigator colleagues, so Megan Furnival at London Health Sciences Centre, and to Julia Simeone and also Dr. Beth Murray Davis at McMaster University Midwifery Research Centre. I'm also a scientist at the McMaster Midwifery Research Centre. So the next few slides, apologies up front, there's some busy slides coming on, but don't worry, I'll talk you through it. This is kind of a nice representation of the 5 steps of evidence-based practice. So as we all know, you start with a clinical scenario that you have some questions about. That develops into a researchable question that we can search for, appraise, apply the relevant research, and then evaluate how well we did all that, like what we could improve on last time. Did we get the information we needed? Evidence-based practice is valued by midwives. I don't need to tell you that. And it's very consistent with the midwifery philosophy of care, right? International, national, provincial guidelines all recommend that we employ evidence-based practice in what we do. But we know that there's a lack of midwifery confidence in evidence-based practice skills, being able to go through this cycle that's depicted here, for example. So, when it comes to midwifery practice, midwives can lead in closing the gap and changing their own practice behaviors, but also the practice behaviors of the colleagues that they're working with in the multidisciplinary team. We know that workplace culture, interdisciplinary collaboration, and attitudes towards evidence-based practice have been recognized as crucial drivers of change in clinical practice. But we need a multidisciplinary approach in order to target organizational and interdisciplinary change. Like, we can do it as midwives individually, but we also need to try and affect change at the organizational level too. That's really important. And of course, we know the harms or the impact of not doing evidence-based practice. It can lead to suboptimal or outdated or even harmful care. So it's really worth doing. So one solution that Beth and Megan and Julia and I came up with is the development of a clinical academic partnership for evidence-based practice for midwives. And again, this representation, it kind of demonstrates what that looks like. And this, each of these little bubbles outlines the individual team and organizational domains that are involved in a clinical academic partnership. And you can see with the red arrows, what we focused on at London Health Sciences is kind of the left-hand side of that diagram to start with. We wanted to bring midwifery-related research evidence into multidisciplinary care decisions. And rapid evidence synthesis, or rapid systematic reviews, are one way that we can meet this need. Evidence synthesis, or bringing together all the studies on a topic and looking at them critically and summarizing them in some way, it's important to do because it allows more information to be brought into clinical decision making. And organizations like Cochrane or Campbell, they spend a lot of time developing systematic reviews to try and keep abreast of all of the current health research on various health topics. So these clinical academic partnerships are set up in such a way that we are trying to develop skills and confidence amongst clinicians who are interested in promoting evidence-based practice, supporting linkages and partnerships between those clinicians and other members of the multidisciplinary team. We want to ensure that research is close to practice. It's much more relevant to do research that directly relates to a clinical issue. Develop appropriate dissemination, so good ways of sharing so that everybody's aware of the results of that research. And then kind of more organizational things that need to happen, like investing in infrastructure and building sustainability and continuity. Oh, hang on a sec. Just a sec, Meg, I'll let you loose in a minute here. So clinical academic partnerships benefit clinicians by helping them to access the research, funding that's available for it, and administrative support. So kind of not just developing their skills, but also kind of developing an infrastructure that's something ongoing can be developed and used over time. And it also benefits researchers by identifying real world problems and giving researchers access to data that they might not otherwise have. So it's a good thing for both parties to be involved in. So we developed a process to support evidence-based midwifery practice at London Health Sciences Centre through a combination of interest holder engagement through an advisory group, and then involvement through the training conduct of rapid reviews by clinical midwives. And this project is very much an exploratory study. So we're just looking at developing an intervention that we can then roll out later on. Okay, Megan, I'll turn it over to you.
Great, Jenny. Thank you. I'm just going to go ahead and make sure I can advance the slides. So I'm going to expand on what Jenny has said. And so full disclosure, we're kind of doing a couple of things in this project. One is the actual review. And then the second piece is trying to look at building out the capacity to be able to create this framework for how this can be done in other centers. So the funny part of the project is that we kind of called it a rapid review, and now we're laughing because it wasn't so rapid, because it's taken us 3 times as long to figure out exactly what works and where we would change it moving forward. So it's been a really fun project to work on with Ginny, and to see the midwives grow in their skill sets over time. So I'm going to talk a little bit about what we did here. So again, Ginny said we started with the initial clinical academic partnership. And what you'll see is in many organizations that aren't affiliated with an academic center, there's a bottleneck in midwives being able to build research capacity because they just don't have the support to be able to kind of walk through building that. So we started with the partnership with MMRC and LHSC. And at the time, we'd been trying to change clinical practice regarding skin to skin in the operating room. We're a large center, and there were a lot of opinions about the safety and how we were going to be able to do that across, and who was eligible for it, and a whole bunch of other things. So we felt like choosing that topic was well aligned with what the stakeholders and the other clinicians would be interested in. So that was the first thing we did. And so we were in the process of meeting with the stakeholders. We'd noticed that they'd had different opinions about who we should include in and being able to do skin to skin. And there was honestly quite a bit of disagreement. So we had, what we did was we actually went through, created an advisory group, and the advisory group was all of the departments that had an interest or wanted to have their opinions sort of spoken about how we were going to do this intervention in the OR. And when we created that advisory group, it was really interesting because we had our initial meeting, and then there's always like a meeting after the meeting. And after the meeting, there was a lot of discussion about how it was like a really nice way to build interprofessional collaboration. And in our world, evidence-based medicine or evidence-based practice is sort of the gold standard. It's been that way for 40 years. So people often default to science as truth. And so it was one way we could come around the table and have a curious conversation about what we were going to do on the front lines through evidence. And having midwives run or sort of facilitate that was very interesting, because as you know, we're all very passionate about the work that we do, and we're on the front lines all the time with a unique perspective. So we had all the stakeholders together. After the meetings, we had others come out from different departments to say, hey, we would like to actually do more of these rapid reviews within our own departments to get some sort of decision-making power. So it's a very fascinating exercise, which we hope to evaluate later. And so before we met them, we did a kind of a brief scoping review of what existed in the data, so we could give them the perspective of what was saturated, what clinical outcomes in the first hour after birth were saturated for the birthing person and for the baby, and which ones were there a lot of gaps in, and which outcomes really didn't have enough data at all to even look at doing a review for. So that helped guide the discussion, and that's what ultimately ended up us finalizing that first hour after birth in the operating room. What does the evidence say? So then after that, we created our collaborative research team. So we had a core research team of research coordinator, research assistant, Ginny, myself, Julia, and Beth Marie Davis. And then we had the midwives that were going to make up the committee that was going to help with the review themselves. And so as we were going through that, we managed to get all of the studies we felt were relevant. And then we actually created training videos for those midwives to be able to understand how you actually go through the review process. And so key determining factors here for success really were having a group of dedicated core research team members to help meet milestones within the project, keep the project moving, and then be able to sort of keep tabs on who needed to finish their articles and who needed to finish their screening and those types of things. So once now we're at the point where we've done all of our screening and we're in that data extraction phase, and we're hoping to be able to head into data analysis shortly. And so then the advisory group helps us determine what deliverable matters here. And so with something like skin to skin in the operating room, there's actually quite a bit of data on it, which is what surprised us a little bit. So that now this rapid review wasn't so rapid because there was a lot of data to go through. So we're actually looking at potentially doing a scoping review of that because we have so much useful data. But then what's nice about this is that if you're working in an organization and you have a clinical topic that you're particularly passionate about, ours next one is really water birth. And so if you have a group of clinicians that feel passionate about a topic, doing a rapid review or some sort of evidence synthesis is really helpful because you gather all the data, you get the stakeholders together, and then you get to see the landscape and you get to sort of see what kind of program of research or what kind of research work you want to do within that space. So for us in particular, we have another skin to skin project that will be happening in 2026. So it's interesting looking at which outcomes are setting the foundation for that next study and what we want to be looking at. So for us, maternal mental health or mental health in the postpartum is something that we're very passionate about. And so there's a data gap there as well. So just looking ahead at future projects, this is the kind of foundation that we've built. So then the advisory group will help advise which deliverable matters. So is it a grand rounds that they want for us to do to report on the findings? Is there a manuscript that we should be publishing? Is there other kinds of KT deliverables that would be beneficial? And then finally, Ginny, so we're looking at how do we evaluate this, right? So how do you create a framework that's multidisciplinary, particularly midwifery-led? What are the impacts of that in the hospital? And I can say, as a leader in our healthcare space, Lauren and Sarah and I can attest that having midwives, and I'm sure many of you who work in leadership, having midwives at the table in these types of rooms, making decisions, it's a very important perspective to have, especially because we bridge frontline community work with hospital work. And so this kind of work, I'm very curious to see what the impacts of something like this will have on an organization. So our aim is to conduct a mixed methods process, evaluating the clinical academic partnership model, and to ultimately build research capacity within the LHSC midwifery department. And ultimately, we're going to collaborate with clinicians from other departments to work together to answer some of these questions to drive clinical innovation and change in practice. Obviously, this is time, so funding is very helpful in these kinds of situations. And so the framework that we are going to be referring to is Joe Cook's framework on research capacity building. And so Joe Cook defines that as a process of individual and institutional development, which leads to higher levels of skills and greater ability to perform useful research. So it's building research capacity. It's not just about teaching people to do research. It's about creating a supportive system that allows research to happen and keep happening. And there's a reason why we sit around tables and we have great ideas, especially as people in different departments. We have a pretty good handle on the problem, but we don't always know how to take that idea and get it into frontline solutions. And so this is a great way to do that, is to build that system. Cook's framework also, it helps design and evaluate research capacity initiatives as well. So it can guide funders, it can guide organizations or leaders to track progress and outcomes beyond just publications or grants. It's flexible. It can apply to clinicians or departments, even universities or regions. And so Cook argues that research capacity building doesn't happen in isolation. You can't just train individuals and expect sustainable change. You need to build skills and structures and culture at every level of the system. So when we look at evaluating this, we're looking at evaluating the framework in the short term, in the medium term, and in the long term. And so from a short-term perspective, we're looking at reflecting on what were the skills that were developed within the midwives within the department, how much confidence was built in that, in the critical appraisal process, in the review process, understanding how to go through a review from a research conduct perspective, and then what's the sustainability of this model. And there were definitely some key learnings for us. Midwives are really need to work asynchronously because of the nature of our work. So that matters to us. And then medium term, we have organizational impacts, looking at what are the impacts of midwifery-led research focused initiatives. What are the impacts interdisciplinarily? What are the impacts on patient or client outcomes? And then looking at the long-term impacts, the super organizational impacts. We also were lucky enough, MMRC was lucky enough to get a grant. They have the McPherson grant, I believe it's called. They were awarded to actually make some tools and training resources for midwives to be able to learn how to do evidence synthesis. So good things are coming, lots of work ahead. But otherwise, we're open to questions, and we're hoping that someday we can share the findings with all of you so that other centers that are not necessarily built into an academic center can build some of the research capacity that they want to make an impact as well.
Thank you both so much for sharing. I'm not seeing any questions in the Q&A box, but please add any that you have. In the meantime, can you share any of the barriers that you faced in getting the Rapid Review Committee together, or for the midwives that were working and doing research? You mentioned about the importance of midwives working asynchronously. Sorry. Was that a major challenge, or is there anything else that you could share?
Jenny, do you want me to take that one, or do you have something you want to offer?
That's probably your perspective, Megan, really, in terms of the advisory group.
I would say, I would say there's definitely, I think, funding's always an issue. Compensation for time is always an issue, I think, but in reality, when you divide up things, the key driver I found of success was having a team lead that was tasked with making sure the project was moving. So where are we at with title and abstract screening? Where are we at with full text? And Julia Simeone is fantastic. She really drove that. And I would be misleading you or anybody else in saying that, sure, you can just grab a bunch of midwives and just get a review done. It doesn't really work that way. We are very busy. And especially when you're learning, you need to take time to learn how to do these things. So the first one you do is going to probably take a bit longer, but it's really nice to see once you get in the groove of the process, how quickly it can go. So yeah, I would say just the nature of our work, the way we do evidence synthesis as a team is probably going to be unique to that clinician lifestyle. So that was a barrier. Having someone drive the project was key.
I would also add that, in evaluating this project and what it, the benefits to it, the challenges to it. One of the key pieces of information we need is input from the clinical midwives that we worked with, because of the nature of the demands that were on their time. What gets developed as an infrastructure should be taking into account the demands on midwives' time, on clinical midwives' time. So we need to be aware of that so that we can think about how to factor that into training or an infrastructure for a program like this moving forward.
Thank you so very much.
All right, I'll take over in terms of introducing our next person here, because it's going to be Sarah herself who's going from host to presenter. And so Meg's going to throw Sarah's bio into the chat, and Sarah's going to get started with her presentation on free birth in Southwestern Ontario.
Well, thank you. So a year and a half ago, I started my PhD journey, and I decided to look at the experience of individuals who had chosen to free birth, in part due to my experiences in clinical practice of supporting clients who have made choices outside of community standards, and the reality of what we were seeing in our community, which is an increased frequency of free birth. My goal for this presentation is to explore why families have chose free birth as their option and how healthcare providers can better support diverse birthing choices. What is free birth? It's the intentional choice to birth without the attendance of a registered healthcare provider, specifically a physician or a registered midwife. There have been several names for free birth over the last number of years, including autonomous birth, DIY birth, sovereign birth, and an intentional born before arrival. These are very different situations where these are very different situations from labor that's precipitous or the delivery happened prior to the arrival of the midwife or arrival of the birthing person at the hospital. And it's different from a delivery with paramedics and attendants or situations where patients were unaware they were in labor due to intoxication or incapacitation. Free birth is often misunderstood. It is planned, prepared for, and intentional. Motivations for free birth have been looked at in several countries, including Australia, Netherlands, Denmark, England, Scotland, Ireland, and the United States. And a lack of access to midwifery care and lack of home birth options were frequently cited as motivations for choosing to have a free birth. The research that I'm doing is different in that it's looking at the decision to free birth in a region where midwifery care is widely available. So this insight will provide a deeper understanding of free birth and help healthcare providers to better meet the needs of families. So a traditional birth attendant or a companion is often hired to support and provide companionship throughout the journey to parenthood. They may provide some prenatal appointments for information and planning of the birth. They'll provide practical support postpartum, including cleaning up and making meals. But most commonly and importantly, they are hired to be present throughout the actual birth to share their reassurance and knowledge of the birth process. The role is one which is non-clinical, although what that can mean differs from person to person and birth to birth. Some traditional birth companions have attended births with very little previous knowledge, and others have vast experiences that they have either gained themselves or through previous education. They may partake in classes or education with other traditional birth companions, and these classes can include a wider range of topics, including nutrition and physiologic birth, including breech and twin births, as well as some recommended readings. Doulas differ from TBAs in that their role is non-clinical support and care during childbirth and possibly the postpartum period, if that's what's been arranged. And it includes practical, emotional, and informational support and helping people to advocate for themselves. Research has been shown that doulas are able to provide a more positive labor and birth experience, which includes shorter labors, less interventions, less need for pain management, and fewer interventions such as C-sections and assisted vaginal delivery, as well as improved breastfeeding rates. There is a stark lack of Canadian research on free birth. There was a study in 2015 which looked at choosing to birth outside of the system in New Brunswick. However, that was not solely incidence of free birth, but rather a systemic issue of unregulated, unfunded midwifery care and lack of home birth options. And so while midwifery care in New Brunswick is now regulated and funded, it's still lacking, with a total of 6 registered midwives in the province and only 4 of them are actively practicing. There was also a previous paper that looked at the experiences of rural women in British Columbia, some of whom had unassisted home births due to a lack of midwifery services or distance to care. More recently, in 2023, there were a group of researchers associated with Queen's University and Dalhousie University that published a systematic review of experiences of women who had planned unassisted home births. But the studies that they looked at included participants from the US, Sweden, and the UK, but not Canada. There is a new study that was just released earlier this year looking at free birth and the influence of social network systems on the information and decision-making of women who have chosen to free birth. So midwifery care in Southwestern Ontario is quite prolific. especially in comparison to certain areas of the province or in the wider Canadian context. We have 74 community-based registered midwives and 8 midwifery practice groups, all of whom hold privileges at one or more of the 6 hospitals which offer obstetrical services spread across each of the 5 counties. So lack of access to home birth care should not be a reason for people planning a free birth. The frequency of free birth in Ontario is very difficult to obtain, and there are many factors for this. If the birth was planned as a free birth and assistance with the healthcare system was sought at any time in the labor or the immediate postpartum, then the birth would have been registered under the physician or midwife who was in attendance. If the midwife was called after the fact and asked to attend the birth, then they may have registered the birth under them. But what we know is that we have seen families arrive at our hospital doors or calling their midwife to come due to complications in labor or in the immediate postpartum period. Understanding free birth is crucial for improving healthcare for all. Previous negative birth experiences are commonly cited as motivations behind free birth. It's not necessarily the result of a major obstetrical emergency. In fact, it's rarely the reason cited for birth trauma. Instead, it's often linked to lack of communication from providers, a lack of understanding and explanation of procedures, and lack of informed consent. All of these factors contribute to a loss of trust in the healthcare system. The desire for autonomy and trusting in oneself are often cited as motivations for free birth. Choosing to free birth enables individuals full control over the birthing process. They often express confidence in their ability to recognize normal physiological progress through the intuition and knowing and when to seek help if needed. Spiritual and physiological beliefs are identified by people who believe that birth is sacred physiological process which should not be interfered with, and they hold a deep belief and trust in their body's ability to birth without medical intervention. Concerns regarding over-medicalization of an otherwise normal physiological process have also been identified as contributing factors. The contemporary medical system's approach to childbirth with high rates of interventions is a significant concern. Whether it's IVs, continuous electronic fetal monitoring, routine checking of vitals, routine cervical exams, all of these things have been noted. And while they might be routine, they don't improve outcomes in physiological birth. Comments from participants in my research included concerns regarding the significant intervention rates, including C-section rates near 30%, which are 2 to 3 times higher than that recommended by the World Health Organization. And some participants believe that staying out of the system reduces the risk of unnecessary interventions. All of the participants in my research understood that there can be complications with birth, and they were willing to seek help if they determined it was necessary. And for the participants in my research, some in fact did seek help when they felt it was needed. Each person has their own unique set of experiences and beliefs which led them to choose free birth, but autonomy was a central theme for many of them. So just how common is free birth? According to Ontario Vital Statistics, these are the number of birth registrations which were attended from 2013 to 2022. And the total number of births without a physician or midwife in attendance for either the birth or the placenta delivery. This includes births without a registered healthcare provider, whether or not it was intentional. And it does not include those who intended to have a free birth, yet ended up seeking assistance. When we look closer at the numbers of unattended births in southwestern Ontario, the frequency mirrors the provincial increase, which has climbed steeply since 2019. So the gray bars, they were looking at the areas outside of southwestern Ontario, and the line is looking at the number of recorded births without a registered healthcare provider within Middlesex, Lambton, Essex, Chatham-Kent, and Elgin counties. Healthcare providers typically react with disbelief or disappointment to free birth. They may struggle with their feelings of blame if there were complications in cases of morbidity or mortality. The ethical dilemma between respecting patient autonomy and ensuring safety is complex. Midwives in Ontario follow 3 tenets of care, one of which is informed choice. Midwives believe that it's important to provide clients with information, education, risks, and benefits. And this ensures that clients have the information that they need to make the best decision for themselves and their family. However, people who choose to free birth are still feeling that no midwifery care is a better option. So why is it that no care is felt to be better than some care? It is the restrictions that individual healthcare providers have imposed. One participant spoke about how during their prenatal appointments, it seemed like their midwife believed that some informed choice discussions were important, but if the client's choice was not meeting their professional or the community standards, then they would revisit the topic and the client's decision multiple times on separate visits. Another participant shared that with her first birth, she felt that the midwife had done a bait and switch, where the midwife was seemingly supportive of her choices until she was post-date, and then she recommended several interventions, which cascaded and resulted in a C-section. Or, as shared by several participants, there are misperceptions that declining community standards or recommendations were not allowed within midwifery care. International research on healthcare providers' perspectives on free birth identifies professional concerns, ethical issues, and systemic barriers as themes. Healthcare providers often view free birth as unnecessary and risky, with significant concerns for the potential of complications. And many providers feel that there are medical legal considerations and institutional constraints on their practice and ability to support choice. Risk management within the healthcare system is often thought to involve technology and acting or intervening, despite a lack of strong evidence to support these actions. The discussion of balancing autonomy and benevolence for many healthcare providers is challenging. And when asked, many healthcare providers acknowledge and value a person's autonomy and yet right to choose, yet they personally and professionally feel a strong responsibility for the outcome and well-being of both the birthing person and the infant, which can lead to ethical conflicts. Just a brief overview on my research. So I've interviewed 11 participants. 8 were birthing people, 3 were partners, all lived within or gave birth within Southwestern Ontario, and we had in-depth involved interviews. The interviews involved participants sharing their birth stories. While not the goal of the interviews, all of them shared their motivation for free birth. And it echoes that has been found in other research. And I'm just aware of the time, so I'm going to skip over a couple of slides. This is a summary chart of my participant demographics. Participants ranged in age from 25 to 41. Their education levels ranged from high school to multiple master's degrees. Some had traditional birth attendants, some had a partner, and one did not have any adults at home at all. Some families shared their plans with their friends and family members. Others chose not to share their plans at all. One participant had created a binder of their pregnancy and shared their story with a close family member only very recently. Participants who did encounter situations where they opted to call for assistance felt frustrated by their lack of choice. One participant felt that a very simple procedure could have made the difference in their birth experience, and when they called for assistance from paramedics, it was outside of their scope and necessitated a transfer to hospital. Both parents commented on the amount of interventions that then occurred, and yet the treatment that she thought she needed was accurate, and the birth progressed fairly quickly thereafter. The interactions with hospital staff, including the obstetrician, were to their surprise quite positive and helped to bridge the gap in seeking care within the healthcare system in the future. So as healthcare providers, we need to start by avoiding the breakdown of trust in the healthcare system by providing patient and family-centered care in all interactions within the healthcare system. The importance of patient-centered and true informed choice are undeniable. Recognition of the importance of trauma-informed care has increased over the last 2 decades, and it's based on an approach which acknowledges the impact of trauma on individuals and aims to create a safe, supportive, and engaging environment and services. Pinnacle to trauma-informed care is empowerment, voice, and choice, the lack of which are motivations for avoidance of the healthcare system. Playing the blame game is not helpful, nor is it empowering or supportive, and it's certainly not going to change a current situation. Approaching each person as an individual with individual beliefs, choices, and goals will go a long way to bridging the trust gap and provide appropriate and needed care, and even potentially opening the door for families in the future. Some practical strategies for healthcare providers to support free birthing families include approaching free birthing families with respect and curiosity, support clients who transfer to hospital post-free birth without blame, meeting their needs, not our own, and reframe risk discussions to empower decision-making, education on what to watch out for or how to tell if there are concerns, such as fetal movement expectations and why it's important, or normal newborn breathing, will provide information, education, and empowerment to parents. Healthcare policies can evolve to support all birthing individuals better. Advocating for continued education and systematic improvements is the responsibility of all healthcare providers. Physiological birth is affected by the environment. How we can offer a balance between hospital protocols, including monitoring, and an unobtrusive private environment which supports physiological birth. So the question that needs to be asked is, do our current care models meet patient needs? And when I would argue that with increased frequency of free birth as a result of the rejection of mainstream healthcare, we are not meeting the needs through our current care models and can do better for all patients. So in conclusion, free birth is a response to systematic issues in healthcare and specifically maternity care. Accurate information with clear communication, which is presented in a manner which seeks and accepts the choice of the individual, is vital to person-centered care. And person or family-centered care has been shown not only to improve satisfaction, but also improve health outcomes and lower costs to the healthcare system. This type of individualized care does require us as healthcare providers to receive training. It takes time to ensure education and understanding with the patient and family. It requires systematic changes in which shared decision-making is prioritized and recognition for patient preferences and values, and the importance of holistic care is prioritized. Supporting and enforcing patient-centered care in all healthcare settings, and especially within the obstetrical care center, provides the platform for patients or clients to feel heard, respected, and empowered, the effects of which are life-altering. You can ask any elderly person who has given birth, and they will be able to tell you how they were made to feel on the day they gave birth. If they were supported, listened to, and respected, that would have influenced their journey as a parent. Likewise, if they were ignored, not spoken to, threatened, coerced, or had things done to them, then they will have started their journey into parenthood broken, scared, and full of self-doubt. The cost to those families directly into the healthcare system more broadly is significant and very difficult to determine. All healthcare providers are vital for improving care, and midwives in particular have a long history of advocacy for their patients and a holistic approach to healthcare. Trauma-informed and culturally safe practices were regularly practiced and acknowledged as vital to providing competent care. Providing true informed choice, as embodied in the Ontario Midwifery Care Model, not only meets the requirements, but does so in a manner which meets the needs of diverse clients. Thank you.
Thank you, Sarah, so much. This work is fascinating and it's also so important. And I think of all the times that for anybody who's in leadership positions at the hospital level or other organizational levels, the number of times we spend reviewing cases and outcomes and acting as like a communicator or translator in some cases from the client to other stakeholders or department clinicians. It's really interesting the perspective that we bring. So I thank you for that. I'm just going to open it up for questions in the Q&A. We do have time. So if you have something you've observed, something that you want to, even a comment, please put it in the Q&A. I have a couple questions because I think this is fascinating work. I'm just going to find where I put them. So the first question I have for you is, I know you kind of touched on this, but what systemic barriers in maternity care contribute to the rising number of free births in Ontario, and how might these be addressed? So I know it's a multifaceted issue, but can you just give me the Reader's Digest version?
I think the Reader's Digest version is that client's choice is choice. And if they choose to do something or not do something, they are not doing it to be spiteful against somebody. They're coming at it very thoughtfully. And I think that assuming that families who choose to free birth have not given it a great deal of consideration and done their education and prepared themselves for this process. But we're not offering physiological birth options supporting their choices well enough. And so doing things like having policies where vaginal exams are done on an interval time frame, or progress has to happen at a specific a specific frequency. Otherwise, we need to intervene. We must do it. It's something as simple as supporting who can be in the room with them, what foods they can eat during labor, whatever their choices, whatever is important to them. We need to support that and not make it an institutional policy we have to do X, Y, or Z, because that's just driving people away.
Amazing. I was just going to say that this ties in so nicely to the work that we're doing with the Justice and Equity and Perinatal Services Hub at UBC. I know that there is going to be some more options for people to work with them coming up in Ontario in the next year. But what I'm trying to say is that respectful maternity care is it should be a priority, but it is something that there is validated tools for centers to use to be able to score themselves on those domains, like the things that you mentioned around eating and drinking in labor and delayed cord clamping, skin to skin, all of the domains that come under respectful maternity care. And so it's interesting because when we were talking, Sarah, in a meeting recently with other stakeholders, that came up. The trauma-informed care came up, and we asked family medicine and obstetrics and other stakeholders, what do you think we need to work on here to support respectful maternity care? And that was one of the drivers, was we need to be educating about what trauma-informed care looks like, and with some of the research coming out. So this is very timely work, Sarah, for you to be exploring this. One more question I have. So in what ways can emergency and postpartum care be improved for families who have experienced free birth, especially during hospital transfers?
So I think it's extremely important not to blame them. It's extremely, extremely important not to hold up care, providing care, because of feeling like they, as a care provider, whether it's a nurse or a midwife or a physician, that they need to check a checklist or something like that. So I've witnessed that before, and it was astonishing to me that what the priorities were amongst the staff, instead of providing care and then dealing with whatever you think you might need to deal with afterwards. So if they've come in from a free birth, whether it's for postpartum bleeding or a lack of progress or wanting an epidural, whatever the reason, let's treat that. Let's meet them where they're at and ask them, what do you want? What's important to you? How can we achieve the birth that you were hoping to as much as possible? Because clearly this isn't what you had planned, rather than blaming them for the choices that they have made. Because the choice didn't end up causing the situation. It's just part of what happened in this birth story.
Absolutely. Lauren, do you want to ask something? And I think there's another Ali has a question too.
Yeah, I was actually just going to say that maybe because we have a little bit of time with Sarah's discussion, I will change the controls so that anyone can unmute themselves as participants if they'd prefer to ask the question orally as well, just because I know this topic can certainly engender a lot of a good discussion. And I think my question for you, Sarah, is just related to the trauma-informed care piece. And I know that you and your research has done such a fantastic job about looking at it through the lens, obviously, of the client-patient birthing person's experience. And when we held an artichoke rounds a number of months ago at our institution, where we discussed sort of the impact of a recent very, very difficult free birth case that came in through our doors, we actually heard about the sort of trauma that came through to all of the people who had been involved, all the way through our neonatology colleagues, and just how difficult it was for them to get through that experience. Can you speak at all to, just sort of that intersection between like trauma for the care providers who are involved in cases that don't go well, and how they can remain sort of trauma informed for the clients as they themselves are experiencing their own traumas too?
Oh, that's an excellent question, Lauren. I think one of my participants probably worded it the best, and not from the healthcare provider standpoint, but many of the participants in my research spoke to the fact that they knew that negative things, bad things could happen in birth. They can happen in birth in hospital, and they can happen in birth out of hospital, and they can happen with healthcare providers present and without healthcare providers present. And they were prepared for that. They just decided based on their individual risk factors that it was less risky or a safe bet for them, or a safe risk for them, to be out of hospital without a healthcare provider present. One person had said if they had a poor outcome, if their baby had died in the hospital, they would have blamed themselves because they had chose that. They had consented to whatever interventions had happened, and that would have been their responsibility. The same as if they had been out of hospital and their baby had passed away, then it would have been the same. They would have felt that responsibility themselves. So I think the healthcare provider piece in particular, when I've done reading about it, the healthcare providers, which is not the main focus of my research, but healthcare providers blame themselves and think that the families don't also blame themselves. They think that the families are blaming the healthcare provider, which is not what the families have told me. The families tell me they own that. They feel responsible. They have made the choices, but they have made choices that they feel are right for them, and based on previous past experiences with the healthcare system, positive or negative, that has influenced them to make the decisions that they had made. So from a healthcare provider standpoint, when you're maybe the one that's been called for a situation, or maybe you're caring for somebody and now they want to decline and either not have you attend the birth, or don't want to have any prenatal care, or limited prenatal care. It's just about understanding that they have made this as a very intentional decision. And it was not done lightly, but they believe that this is the right choice for them. So I think when you are understanding that it is actually an informed choice, that it does feel different from a healthcare provider point of view. I hope I've answered that well.
It's a hard one to
It's a hard
answer,
one.
but yeah.
Yeah.
Thank you.
Is there any other questions or comments people have about this, or questions for Sarah regarding her research? It's a hard topic to fit in 20 minutes. Okay. Okay, well, we are so glad you joined us today, and I'm just going to
We just had one pop up in the
Oh,
Q&A.
yeah.
It was Miki who asked if you knew the statistics of adverse outcomes with free birthing.
No, I don't off the top of my head. I do know that I do have it. Hang on. If you give me 1 second, I can pull up the coroner's office had put out a statistic, but I'm trying to think of where I had it. So I can't recall it off the top of my head. It was not a lot. Sorry, I don't have it really quickly, but I do have it and I can share it. That's what
Perfect.
I will say.
Yeah.
Melanie.
It looks like Melanie's got a question.
It's not necessarily a question, just for ongoing research for this, I would be so interested in perspectives from the traditional birth attendants or companions or people on the care that they themselves provide and the care that's offered in like their own communities, which will 100% vary greatly. And yeah, I guess like just getting their perspective on how better we can serve people.
Yeah, I think that's a great idea. I have so many more studies that I want to do now. I have to finish this one first. And it's obviously taking a significant amount of time. But yes, I've got, I think there's so much that we can learn from this. And it's not just people who have been unhappy with the system but are staying within the system. They have made a very conscious decision to go outside of the system. So how can we do it better? And how can we create something that meets the needs? So if people are choosing free birth and they need assistance, what can that look like? Is there a way that we can do that in a that's more accessible, or in a, I don't know, drop in prenatal, just to come ask your question once a day or once a month kind of thing. I don't know. There's so many ideas I have about this. I do feel very, very honored that these families have shared their stories with me so honestly. And yeah, I hope I can do them justice through this research.
Ellie, you have had your hand up. Yeah, I was going to say, do you want to ask a question? I think maybe not. Okay.
And there's also Brittany's question in the Q&A as well. She wondered if the participants had given any indication of how they learned about the complications or risks that could occur. And just whether, how can we gauge like true informed choice, right? As to your one of your previous responses. Yeah.
Yeah, so a lot of people have read the book by Rachel Reed, which is actually sitting over on the side right now. Many of the participants spoke about reading that book. So if you haven't read it, it's Reclaiming Birth the Right. I'm going to say the title wrong. Hang on a second. Let me grab it. Reclaiming Childbirth as a Rite of Passage. Weaving Ancient Wisdom with Modern Knowledge. It's a red book. It's really interesting. So that one was cited by a lot of people. Some of the participants took part in a class that was specifically to teach people how to free birth. There's influencers or so people on social media in the States that shared information that they would speak to. A lot of podcasts were talked about, and lots of reading that they've done on their own. So.
Amazing. Amazing. Okay, well, I think we're almost at time. I'm just going to someone has one more question. Yes. How many times have we been tasked as being, actually, it's a good question. I'm wondering how many of us have experienced being on the floor and being tasked with being a translator and ideas of how to manage that. Does anybody want to answer that really quickly before we finish up? It's definitely something that has happened. I mean, Lauren can certainly speak to that. As someone who speaks French, right? I think.
Yeah, I'm assuming she means translator for those who have chosen
the free birth
option, and like they come in from a transfer, and then effectively, you know, the midwives are asked to explain like why this would have ended up in this situation. And I think many of us probably do recognize that, and that they're, you know, either assuming these people were midwifery clients, or that you know, the midwives would have facilitated it in some way. I think that's pretty common. Yeah.
We do a lot of debriefing. So we were required, like, as when you have a leader, a midwifery leader, then you really should have a debrief and have somebody pull the chart and go through it and make sure that everybody's there. But it's definitely not easy work when you don't have that process in place and you don't have a person to take the case to. Because yes, you do need to sit in a space where you can hear all the perspectives and have a meaningful conversation about it and not make assumptions. So thank you everyone for coming today. So just really quickly, we have our post-conference survey, feedback survey. The QR code is there. I'm also going to put the actual link in the chat as well. And the certificates of attendance are going to be emailed out to the participants in the next couple weeks. So in the survey, you need to put your name down just so we know who to send the certificate to. And then so the sessions are recorded. So we'll make sure that we have them up on the website in the next. And I just really quickly want to take a moment to honor the memory of Jane Erdman. She was a beloved midwife here and an educator and a mentor in London and provincially, whose contributions to the midwifery profession in Ontario were profound and long-lasting. And Jane was known for her unwavering commitment to passionate care, as well as her dedication to teaching and her advocacy for midwifery-led innovation. So in recognition of her legacy, the Jane Erdman Memorial Fund's been established through the Children's Health Foundation. So this fund actually supports the ongoing work of the Department of Midwifery, but there's a special focus on supporting Indigenous midwifery as well. And so if you feel moved to contribute in Jane's honor, the QR code is there, and we'd invite you to visit the Children's Health Foundation website as well. So tomorrow we'll be back at 12 o'clock to hear from a host of, it's pretty jam-packed, a host of innovative clinical programs here in the province. We're going to hear from Pilar Chapman. We're going to hear from some EMCMs out of Toronto. We're going to hear from our Billy Clinic here in London. So please join us tomorrow. And then again, Friday, if you want to take a journey into leadership or just how to show up in spaces in the most impactful way. All right. We hope you guys have a wonderful rest of your day.